Hey, good morning and welcome to Open Mics with Dr. Stites. It's Wednesday, November the 16th. It's cold outside. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. When you live in a big city, a big hospital is likely around the corner or a short drive in case of an emergency, with hundreds of specialists, sometimes thousands, ready to take care of you. But it's different in smaller communities. Nearly 1 million Kansans live in a rural area. That's about a third of the state's population. And for them, healthcare can be a real challenge. Many small towns only have a handful of doctors, and the nearest hospital could be more than an hour's drive with limited emergency equipment and limited ability to see a specialist. And what exactly do we mean by rural? The Census Bureau defines rural as any population not in an urban area or an urban cluster, which is anything less than 2,500 people. This morning, we're going to look at the challenges facing rural healthcare providers in caring for their communities. Questions from our viewers are an important part of this program. We want to hear from you. Get yours sent in to now. Get those sent in on YouTube, Facebook, Twitter, and the Medical News Network. You find those links right here on your screen. Jessica Lovell will join us a little later with those questions. So Kansas Governor Laura Kelly signed a proclamation declaring tomorrow National Rural Health Day. Health leaders from around the state are gathering for the Rural Health Symposium tomorrow in Hayes. Our guests today are healthcare leaders from across Kansas and will represent their hospitals at the summit tomorrow. Larry Vanderwig is an administrator at Lindsboro Community Hospital, about an hour north of Wichita. George Stover is Chief Executive Officer of Hospital District No. 1 of Rice County in Lyons, Kansas, just east of Great Bend. And Carrie Saya is Chief Executive Officer of the Holton Community Hospital, about 30 miles north of Topeka. Chad Austin is with us. He's president and the CEO of the Kansas Hospital Association. We're welcoming him back today. He's been a great guest on our program before. And Dr. Robert Mosier is the Dean of the KU School of Medicine in Salina, is an outstanding family medicine physician, and has done a lot of great work, including being the secretary of KDHE. So thank you all for joining us this morning. Chad, you were in the governor's office when she signed the proclamation. Now, proclamations are nice, but how do they help drive awareness? Tell us what this means.
Thanks, Dr. Stites, and it's great seeing you today, and thank you for everything that you and your team have been doing over the last couple of years. But as it relates to the proclamation, really this is an opportunity to recognize and appreciate rural healthcare providers. In Kansas, we have 122 hospitals, of which about 95 of those hospitals are rural hospitals. When you delve a little bit deeper into that, we have 10 counties in Kansas that don't have hospitals, and we have thousands and thousands of healthcare workers working in our rural areas, whether we're talking about physicians or hospital employees. We're looking at pharmacists, dentists, optometrists, and others. And so it's just a great opportunity to recognize those healthcare workers that are working in our rural parts of the state.
Well, and we should do that. It is a different job. And the folks who work in rural communities, they have to have a broader range of expertise because they don't have all the experts to turn to. For decades, we spent time encouraging preventive health care in smaller communities where routine screenings, vaccination rates, and reproductive health services are lower, along with poor access to primary care. And while those challenges remain, the summit tomorrow is focused on more urgent issues, including workforce shortages and financial sustainability. So, folks, how would you define or describe the top workforce challenges? Chad, I'm going to start with you, but then I want to go around the horn here with everyone.
Yeah, Dr. Stites, similar to some of our urban areas, the workforce challenges over the last couple of years, but more specifically in the last year, has been very challenging for our community hospitals. We've had a number of retirements, people looking at different industries, but it is something I think that there's a lot of opportunities to work in healthcare as well. And that's one of the things that we're excited about to talk about tomorrow, which is how can we inspire the youth of our state to be able to get into healthcare and those occupations.
Yeah, that's a really big deal. Larry and I'm talking to Larry Vanderwig here. You're the administrator at Lindsboro Community Hospital. We mentioned that's about an hour north of Wichita. What are your biggest challenges today?
I think it's like a lot of people. We have a need in nursing. We also have a need in radiology tech, med tech, but also other services and dietary, EVS, things like that. At any given day, you could have an opening there. And so we just keep recruiting and also to retain the workforce that we have. A lot of effort is going into retaining the wonderful workers that have continued with us.
Yeah, that's a really big deal, isn't it? To keep those folks here and keep them working. These have been a hard time. So George Stover, CEO of Hospital District Number 1 of Rice County in Lyons, Kansas. Special challenges that you're seeing, and talk to us a little bit too about some of the financial strain on rural hospitals.
Thanks, Dr. Stites. Just like my colleague, Larry, we're faced with the same workforce challenges within nursing, within our radiology and our laboratory, being centered around community colleges that feed out nursing students allows us to work with those nursing departments. That allows us then to be able to employ some of those, but we're finding that one of the biggest challenges for us is the number of students in the nursing programs, and being able then to have the output that is one of the biggest needs across the state for nursing. The financial strains is also one of those really big challenges for us, because the continuation of reduction of reimbursements. Also, over the last couple of years, we've seen a significant amount of expense related to workforce or supply costs, and those expenses are going to continue with reduction of reimbursements.
Yeah, I think that rise in prices because of a lack of supplies and a higher cost of labor coupled with lower reimbursement has put all of us in the crosshairs, but really smaller hospitals, because the margins are so tight and your ability to find other sources of revenue is just a little harder to do. And so I don't envy that road. And Carrie Sayat, you're the CEO at Holton Community Hospital, just north of Topeka. Talk to us about those, what other challenges you're facing, but also maybe some of those financial things.
Good morning, and thanks for having me on the show. What Larry and George both stated are similar to our challenges, some unique challenges that maybe weren't mentioned. Financially, when we're seeing service contracts come in, we've typically seen maybe a request for 3 to 4% increase. We're now seeing a request for 7 to 10% increase in some of those costs. So that is squeezing on those margins as well. Reimbursements, we do need to talk and maybe gather together. How do we talk with our insurance payers to realize we are paying more for services and yet requesting to get less? It is a financial challenge, a struggle. We've seen less and less specialty doctors coming into our organization. And when you have those services, that's another revenue stream that we typically rely on. And so when you have less cardiology visits coming in, or a dermatology that's retiring or quitting, a podiatrist that's retiring, those are specialty revenue streams that are hard to replace and can't turn around on a dime. So some things we've done within our region, COVID and the pandemic have forced CEOs to talk together. So we're collaborating with our competitors in typically environments that you wouldn't have seen before, and how can we possibly recruit a dermatologist to come into our area together and help on some of those financial challenges.
Yeah, big deal. And what you're doing is so important for the patients in your community. Dr. Mosier, I know you're the Dean of the School of Medicine in Wichita and Salina. Just for a minute, workforce challenges, how are the schools across our campuses trying to respond?
Yeah, great question. And I guess you could say just the fact that we've expanded our 4-year medical education into Salina and Wichita is directly to address some of that need, having opportunities for students who might grow up in a more rural setting that would like to train in a setting other than a large metropolitan area like Kansas City. we hope that that would make the Wichita or the Salina campus a little bit more attractive. Plus, I think it puts them a little closer to some of our rural communities and our providers that are more experienced with some of the challenges delivering rural health care, so that they can experience that while they're in their training. And then more specifically, many of the programs that we've created over the years, whether it's the Kansas Medical Student Loan program to try to encourage students to choose primary care and to practice rural, our Rural Scholars program, which is identifying students from rural communities during their sophomore year in college to go through an early admissions process that once they are accepted into that, they're guaranteed admission to the School of Medicine, which allows them to choose which campus to train on. But again, I think it's important that we get more exposure to rural setting, rural healthcare practice, the challenges to delivering healthcare in a rural setting before our students are actually expected to go out there and try to practice in that environment.
Yeah, I think that it is a great program. The KMS program is really helpful. I'm a little concerned about the rising crisis in the School of Nursing admissions because there aren't enough applicants and school nursing numbers are down, and we look at the workforce shortage. Let me talk to our panel for just a moment about that. I think that, George, I think it was you that maybe have mentioned that for just a moment. Are you seeing it the same thing? Is it harder to get people in? Are you hearing that same story? Harder to get people in, harder to get nurses recruited?
Yeah, absolutely. It's been over the years. We've known that that a nursing shortage was going to occur through attrition, through retirements, and so forth, and the enrollments that we've seen over the last pretty much couple of years within the nursing programs have decreased. COVID probably had a significant relation to that, and what we as healthcare organizations need to do is to work with those community colleges, those universities, and advocate that going into the nursing profession has a significant amount of personal satisfaction, that you're actually helping people. And so we need to be working with them to increase their enrollments.
Yeah, I think it's a big deal. So one of the big topics tomorrow is about workforce and some of the changes going on in rural communities. And one of the topics I understand the summit tomorrow is going to be talking about diversity, equity, inclusion, or DEI. What does DEI look like in a smaller community? And what about caring for the patients? Has your patient population changed? Carrie, talk to us a little bit about what you're seeing in your hospital.
Our patient population and what DEI looks like in our community hospital is looking and making sure that we know what challenges are facing our patients as they come into our facility, making sure that we know what our patient population is, the demographics of those patients, and what is preventing them from getting the care that they need, like their transportation issues, daycare issues, if they didn't have that to be able to get to work. What are all of those different demographics. So making sure that we understand and have resources available. We're just partnering with Avell, who provides our telemetry in our emergency department. We have a subset of Guatemalans with Caquiche dialect that is very difficult to find a translator to understand, even if we've partnered with certain ones, but we have found that Avell does have that. And so how can we get the resources to get that right dialect so we're not preventing that population from understanding the care that they need?
Larry, are you seeing the same story at Lindsborg Community Hospital? Lots of new and different challenges?
Yes, for sure. And with DEI, it isn't just, quite often we immediately think about race or ethnicity, but there's also the challenges of people in poverty, people of different ages. Our geriatric population sometimes have trouble to find rides to get to the clinic or get to the emergency department, or to access care in whatever way. So there's a lot of different ways that we need to evaluate the diversity and equity and find ways to help make sure that everyone can, we provide access to everyone, but not everybody has the same ease of reaching that access. At Lindsborg, we also have Bethany College, where greater than 50% of the population are a minority. And so how to make sure that we address those needs to the best of our abilities, as well as other populations.
Yeah, that's a really good point. So Chad, as you think about the role of KHA and what you're seeing going out in the state, kind of talk about to us a little this whole maelstrom of, okay, we've got different types of folks. We don't have as many nurses. The financial numbers are harder than they have been. Gosh, KHA, it's kind of a challenging outlook.
Well, there's a lot of activities and work for us to be focused on right now, as you mentioned, Dr. Stites. And so we're up to the challenge to be able to work on many of those initiatives and are recognizing that it's going to take a team effort to be able to accomplish what we need to accomplish within our state. So not only are we working with partners like from the other healthcare groups, with the physicians, the long-term care industry, the other healthcare provider groups as well, but we're also reaching out to non-traditional groups as well. So working with the business community, working with the ag community, being able to identify ways that we can all work together to be able to not only help their industries, but also help our industries to be able to kind of focus on what the needs are. We are working with higher education on some of the areas with workforce. We're really excited about those opportunities to see what we can do to get more interested youth in healthcare and get them aware of the different opportunities that there are within the healthcare industry.
Yeah, that is so important. Hey, so let's talk for just a minute about a grant from HRSA. HRSA just awarded a 3-year federal grant to the Health System's Care Collaborative in collaboration with the Center for Rural Health to train up to 40 students in a certified medical assistance program in western Kansas. They start training this fall. For those of you who don't know, the Care Collaborative was started by the health system years ago and since then has helped educate more than 1,800 healthcare providers and deliver care to more than 9,000 patients experiencing a stroke, heart attack, or sepsis, which is a type of infection. Now, one thing we don't always talk about is we've shown that some of this faster, more urgent care helps people survive, especially in some of these very time-sensitive diagnoses we just talked about. Dr. Mosier, let's talk about that for just a moment. Tell us a little bit about that study, about what this new grant is, and then we're going to turn to our other folks here about talking about some of these partnerships and their effect on smaller hospitals. But first, Dr. Mosier, kick us off a little bit. Tell us a little bit more about the Care Collaborative, the impressive results, and the HRSA grant.
Yeah, sure. Just briefly, it's been great to be part of that, to provide support back to many of our rural health systems, rural providers who are, head down and just working as hard as they can to keep up with their workflow and all the challenges they face every day. And being able to work with subject matter experts to bring out evidence-based guidelines and develop protocols that are adapted to the local realities to address some of those time-critical diagnoses has certainly been shown to be effective. And so one of the care delivery models that we implemented early in the Care Collaborative was using nurses and other licensed professionals to deliver chronic care management. But as our folks have mentioned today, with the significant challenge in decreasing nursing workforce and admissions to nursing school, we just don't have extra nurses to put to work doing things like the care coordination and chronic care management. So the goal is to identify a licensed, certified, trained individual, such as the medical assistant, and give them an enhanced training that allows them to be able to work in the role of a care coordinator and to help deliver chronic care management services. We found that those patients that are getting chronic care management, their year-to-year total cost of care has gone down about 20%. Compared to those with the same risk factors, same age, et cetera, that don't get chronic care management, that coordination, their total cost of care go up about 11%. So we think if we can demonstrate, again, the ability to train other individuals into supporting the workforce needs, we can expand on that care delivery model and hopefully draw some of the attention of our third-party payers to see the value of that to add to the reimbursement models that are available to some of our rural practices.
Yeah, they clearly need that. They need a little help with that. So, George Stover, does this sound like a really important program to you?
Oh, absolutely. We've partnered with the Care Collaborative for a number of years. One of the things that we have taken great pride of our involvement is within the Care Collaborative, setting a high standard, recognizing the benchmarks within the stroke and STEMI, providing the necessary standard of cares that can be translated down to our providers in a rural setting to ensure that within those golden hours that we're providing the necessary care and treatment and being able to get them to a high level of care. Working with the Care Collaborative has allowed us to see and value those benchmarks of higher level of care.
Yeah, I think that higher level of care really does make a really, really important difference. The financial picture for healthcare in general is pretty darn complicated. The bigger the hospital, the more zeros around it, but core issues are essentially the same, and including the things we've hit on about rising costs, workforce needs, supply chain, et cetera. We've talked about the financial picture. One of the more important programs with the government, though, is the 340B drug discounting program. Now, before we get success, all 340B does, it says if you take care of a lot of uninsured or Medicaid patients, you can buy drugs cheaper than the average wholesale price. And it doesn't cost anybody except the pharmaceutical folks a little extra money because they have to sell it cheaper to some hospitals. I think this is really big, a very important program. Pharma tends to have a very high margin. Rural hospitals, academics, our margins run 1 or 2%. Across the country, difficult outlook if you look to Stanford and Poor and Moody's and all those folks. How does that affect you guys? I think that my sense is 340B is critically important. Let's talk to each of you a little bit about what that means. Carrie, I want to start with you.
Sure. 340B is absolutely essential to the viability of our organization. We've been able to take those savings and invest in a outpatient intensive behavioral health services for our seniors within our community. The savings that the individual patient receives as well is another important aspect for 340B. We just have seen changes within the 340B program within the last year, and being able to, at the same time, having decreased financial profits and having to pay more with some 340B drugs not being on that list of being able to purchase, it's really been impactful. So it's an essential program, and it's essential to our community as well.
Larry, it feels like pharma is kind of trying to push it so they don't have to discount drugs so much, but the impact on rural hospitals is severe.
Yeah, Dr. Stites, you mentioned a 1 or 2% margin for larger hospitals, but I think for a lot of the small critical access and other small rural hospitals, the 340B may be the only reason that we have margins at all. And it's not just helpful for us as the hospitals, but also our local pharmacies, especially some of the smaller pharmacies that we have in our small communities. We partner with them through the retail program of 340B in it, and they find that very beneficial too. So they're able to, if not turn a profit, but at least continue to keep their doors open and provide the essential services that we need the pharmacies to provide in our small communities as well.
Yeah, I think it is so important people to understand the impact because, again, there's no tax dollars, there's no government funds that go into this. Pharma charges less to some hospital to provide this type of care in rural areas or in urban areas where you take care of a large number of Medicaid or uninsured patients. They simply don't make as much money on some of these drugs, though they seem to do very well overall. So, Chad, what's the future of 340B, do you think? I know it's a challenge.
It is a challenge, and it's something that we're working hard with our congressional delegation on to really protect the program as much as possible. In Kansas, we have about 80 hospitals out of the 122 hospitals that participate in the 340B program, and many of those hospitals that are participating are located in rural areas. That it's an essential program, just like Carrie and Larry mentioned, to be able to protect that program, to be able to have those facilities offer the services that they need to within their community, but also to help benefit the patients within their community as well.
George, here's a hard question for you. If 340B wasn't there, if it went away tomorrow, what would happen to your hospital?
That's one of those thoughts that I like not to think about, because I think it would be detrimental to our community, to our county, and to our geographic region.
Well, and I think what folks don't realize is that we take those 340B savings, they don't go into some big margin. We're not buying big yachts or whatever with those dollars. We're doing behavioral health. We're doing primary care. We're doing pediatric care, places where you lose money anyway. This is how you afford to have a big behavioral health, any kind of behavioral health program, is you use the 340B dollars to leverage that. I mean, it's just, the American healthcare system is such that we are, especially for places in the rural community and those who are serving a broader mission than just the areas where you make a lot of money. And man, 340B is absolutely essential. Hey, I'm going to check in now with Dr. Dana Hawkinson, Medical Director of Infection Prevention Control. Doc Hawk, what are the numbers like there, brother?
Hi. Yeah, we have the numbers. We've been presenting those. Yesterday, we also presented influenza and RSV, but right now in the hospital, we have 18 active infections, 3 in the ICU, 0 on the ventilator, 15 in that recovery period. And Steve, just looking at the CDC data, over the past 5 or so weeks for which data is available, the overall cases were pretty steady, about 260,000 to 265,000 cases a week. But over the last 2 weeks, it has gone up a little bit to the mid 270,000s, and then the last week for which data is available, it was about 290,000 cases in that week. So I think we are seeing somewhat of a resurgence in the reportable cases. We understand about hospitalizations. Those tend to lag behind the cases by a couple weeks. So unfortunately, it looks like we may be seeing somewhat of a surge, but hopefully more of that last Omicron surge as opposed to the last Delta surge where there was extreme numbers in the hospital.
Yeah, boy, I sure hope that is right, because hospitals are full across the area, across the state. One thing just to point out, too, this is the first major cold wave across the United States, and this is driving people indoors. This is when we start to see the real impact of things like that.
Yeah.
So there are some flu season red flags that are out there. Early red flags suggest it's on track to be a very, very difficult year. The latest data from CDC's FluView, that's a nice way to say it, FluView report show extraordinarily high numbers of positive flu tests reported from labs around the U.S. As of November the 5th, nearly 14,000 positive flu tests had been reported, as shown in that orange line on the chart. That's more than 12 times the number reported at the same time in 2019.
Yeah.
Okay, Hawk. I'm not liking the number there.
No, and overall, it looks like it's more cases early on, especially, and hospitalizations in more than a decade from the last from the data that's available from the CDC. So it is disconcerting for sure. We know that the major strain that is going around is the H3N2. There is also some H1N1, but we are believing that there is fairly good efficacy of the vaccine this year to help protect against symptomatic infection, but of course more importantly is hospitalization. And that's why it is even more important, especially if you are at risk, to get tested early and get on the drug therapy with oseltamivir, which is available by prescription. So that is very important.
Also known as Tamiflu by everyone.
Tamiflu would be the brand
You
name.
ID
Yeah.
doctors have to
I know. Well, I wanted to be.
Okay, so let's look at a couple of graphs. So heat map. Let's see what the heat map looks like. You talked about COVID. There it is. It's starting to look a little more. Again, the Southwest has kind of led the last two surges. So we'll see how that goes across the United States. The next is a table, and I just want to show it to you. Remember, we talked a lot about BA5, and if you look at this, you start seeing the BA. Was it 1.1.1 or something in BA2 or BA1? Lots of other variants up there, Hawkeye. So, you know, we've had BA5 has been dominating the area for a while. It's barely the dominant variant in the U.S. by only like 1 or 2 points.
Yeah.
It's probably, in fact, by this week, it's no longer the dominant variant out there.
Yeah.
So how much do we know about these others?
You know, we don't know a lot. What we do know, and we've heard this in the media, is about the immune evasion. Again, what they're talking about is the antibody evasion. The antibodies are one of our first line of our adaptive immune system to help protect against infection, but also once the virus is in the body, further infection of our cells. So we know that there is fairly good evasion of those antibodies from these other variants, but we still do know and believe from all the data that we have so far that we still have those very good T cell responses for those areas of spike that are really unchanged as compared to those areas where the neutralizing antibodies bind. But we also know that getting vaccinated and being up to date with your vaccination can increase those rates and those titers of antibodies as well. So we'll wait to see what happens. It's kind of like a battle royal. It's a virology battle royal, really, to see which.
Did you just call it a viral battle royal?
Yeah, it's like a UFC of viral variants, and I think it'll be interesting to see exactly which one becomes dominant.
Okay, I want the easiest one to be. I want the easiest one to be Patrick Mahomes and dominate the area.
The good news is still that our vaccines do continue to have good efficacy against hospitalization, severe disease, especially if you are up to date and are in those high-risk groups. But also right now, we still have very good activity of remdesivir, but more importantly, Paxlovid for that outpatient setting if you fall into that high-risk group as well.
You know, God bless the T cells.
Yep.
That's all I'm saying. Those B cells have a short memory, but those T cells, man, they hang around a little bit.
Yeah.
So, all right, Jess, let's see if we have any reporter questions out there today. And if not, let's get into our community questions. I bet we have a few.
All right, let's do. So Tom is asking, are people in small communities still hesitant about getting the COVID vaccine?
All right, let's turn to our panel. I'm going to start this time with Larry. Larry, people still hesitant?
You know, I think there is a level of hesitancy. I'm not for sure statistically if it's that much different than what we find in some larger communities, but there is some hesitancy or at least fatigue. I know a number of people have already been fully vaccinated, maybe have received one booster, and so now they're wondering, well, do I need another? You know, how many boosters am I going to need to keep up with this? And so that's part of it as well.
Yeah, I think that's probably true. You know, the good news is that the CDC, I think, is going to simplify this a little bit. It's going to probably be one booster a year. It may be two if there's a really strange variant out there that we have to go after. But, you know, earlier, Hawkeye, they announced that they're planning to kind of go to one a year.
Yeah, and that is kind of concerning, but we'll wait to see what the evidence shows and what the data analysis shows and what their recommendations are, because we know that there are those high-risk groups that continue to be at risk of hospitalization, severe disease, and maybe having one a year may not fully reduce their chance of those severe outcomes. But we'll wait and see what happens, and we'll see what the data from these new bivalent boosters show us as well.
George Stover, how much hesitancy is there about vaccines out around Lyon County? Or Lyons County, sorry. Rice County. My mistake.
I would repeat what Larry said. I think there's some evidence of hesitancy within Rice County, more in the fatigue, more in maybe some, I don't know how you would maybe describe it, but more of the booster comes out and then it goes for a period of time, and then here comes then another booster, and then so forth, and there's just maybe some hesitancy of how many times am I going to have to do this or whatnot. And so just the unknown is probably causing some wariness.
Yeah, well, and I understand that makes sense. I mean, we haven't been able to settle into a clear pattern like influenza. Let's once a year, let's get your influenza vaccine. It's going to last you about 6 months. That gets you for the flu season. I bet we settle again. I think we're going to settle into this pattern because the COVID season is really going to turn out to be the winner because people are going to go back indoors and there we'll see a more rapid respiratory spread. And so I suspect we'll see something around that and again pivoting for more serious infections. So Jess, back to you.
Okay, so a joint question from Donna and Susan asking, can smaller communities grow their own healthcare workforce? How do you get high schoolers interested in pursuing a medical career? And then what are the conversations about expanding space in community colleges, increasing their numbers?
All right, Carrie, let me start with you about what do you think about trying to get more workers locally? Are there ways small rural hospitals can do that? Gary?
I'm having difficulty if you're asking me a question.
Oh, sorry. Yeah, I was asking whether or not you thought there was a way for small rural hospitals to get people interested in healthcare locally and help get them trained.
I think you asked about how do we get interest within our local community for healthcare careers, and we've partnered. I wish we would have partnered and done this 5 years ago, but we're doing it now, getting into the high schools and looking at our first ever summer internship this summer. There is a lot of interest within all of we have 3 community high schools within our county. There's a lot of interest in the variety of healthcare careers, but we're really trying to push not only those typical nursing physician careers, but the radiology tech, a medical technologist. Those are needed anywhere you go. So how do we expose those kids and bring them in at an early age, even into the junior high, high school area? So we're looking at getting back in. The pandemic's been difficult to bring students into our community hospital. So how are we getting them in? And we have plans this spring to do that, as well as an application program for next summer for internships, paid internships positions.
That sounds like a great thing. Bob Mosier, you had to wrestle with this as Secretary of KDHE, Dean of the School of Medicine. The rural communities, I think when they take some of these initiatives, it feels like it's going to help.
Yeah, it's challenging because it's a long pipeline in some of the licensed professions. A physician, obviously, you're looking at 4 years of college, 4 years of med school, and 3 years of residency at least, and even with nursing, 4 years for your bachelor's degree, et cetera. So they're not short pipelines, but I think it's great that many of the local communities are identifying the need to look into their growing their own programs. And our Institute for Community Engagement at KUMC, has been working with KHA and others in health occupations classes for some campuses across our high schools. But work study programs. We know of other local communities that have developed some types of medical training academies. But I think it really does start, even down into the junior high level, identifying those kids that have the scholastic aptitude, but also that empathetic and altruistic attitude, who may not have someone that's in a health career, but all they need is a little encouragement to consider that, STEM career and to move forward and to have opportunities for that shadowing. As Carrie mentioned, I think the more the students can kind of see how their local healthcare system works and what their role might be, whether it's administration, HR, you name it. There's so many roles to be filled in our rural healthcare systems to make those systems successful. And the more we can grow our own, I think the easier it can be to recruit them back home and to know that they'll likely stay and retain a lot longer than someone who's not familiar with that type of an environment.
Yeah, so true. Jess?
Just a few more questions. Donna is asking, she says, so you're saying that you're passing those pharmaceutical savings on to patients, but she's trying to square that with the recent hospital bills that she's seen from family and friends.
Yeah, that's a great question. Let me be clear. What happens with 340B is we purchase drugs at a cheaper price than the average wholesale price. Does that discount go directly to a patient? Not necessarily. What happens is that and it can, but it also helps underwrite the programs where we lose a lot of money. People think we make all this money in healthcare. The reality is the average hospital margin across the United States is really low. It's about maybe a fifth or a tenth of what a pharmaceutical margin is. So what happens is we have lots of programs that don't make money. For example, at KU, we have a very large behavioral health population. We have Strawberry Hill for adults, a psychiatric hospital. We have a child psychiatric hospital facility out south in Marillac. Those programs, there's very little reimbursement. So if as a hospital, how do you support behavioral health? Well, you have to find ways to make money. So you make money in some programs, or you save money through drug, and that allows you to expand your overall mission and keep everything open. at the end of the day, your job is to try and balance your books. You know, if you're a company out in the marketplace, you just go charge more money. Hospitals can't charge more money because we're contracted with the rates we are paid by Medicare, Medicaid, and all those commercial insurance. So we can charge what we want. Nobody really pays that. And so that's the struggle we face. Let me turn that over to our panel and ask, guys, anything, or folks, anything that you would say differently about that? Carrie, anything you think different?
No, the one thing when I mentioned the savings to the patient is if there's a qualifying visit and a prescription that's prescribed and they go to the pharmacist, they may qualify, if it's a contracted pharmacy with our organization, they may qualify for getting that prescription at a discount. So that would be the only direct, but otherwise you said it very well. We do try to offset our programs that we can offer that we are not going to make money on by the savings that we have with the 340B.
And I think I asked George this, now I'm going to ask Larry. Larry, if you didn't have this, would you have to close, if 340B didn't exist, would you have to close some programs?
Yeah, we'd have to take a hard look at some programs to see whether we could continue. You know, we're able to do things like Stepping On, which is a program to reduce falls in the elderly population. We do a Safe Center class or classes for our youth, all in the efforts of improving overall health or wellness. And so those are programs that we may not be able to do because, again, they're not funded like other services are. And so we'd have to take a hard look. You know, hospitals, whether it's small or large, we're all here to serve our community to the best of our abilities and to take on whatever comes in our door. And the reality is, I kind of liken us to the Mississippi Delta, to where we catch everything that comes down. If a service provider or to get the supplies that we need, if they increase the charges to us, we're going to have to pay that. If the insurance companies, whatever they choose to pay, we're going to end up receiving. And there's not a lot of things that we can do to try to change that. We just have to make it all work within the confines of the services we provide and the reimbursement, wherever that comes from, whether that's through reimbursement from insurance companies or from patients, from a tax base or grants or other gifts, wherever we can get it, we're going to have to make it all work to hopefully have some margin at the end of the day to retain the workforce that we have to retain and hire new workforce members to provide the benefits that we need to provide, to have the best equipment to the best of our abilities to provide that quality of care that our patients expect and deserve, no matter where they live, whether it's in a metropolitan area or whether it's in the smallest communities in our country or in our state.
Yeah, so true. Jess.
So last question, and Nancy, I will ask your question to Dr. Hawkinson tomorrow, so thank you for sending that in. But Dr. Stites, we've been talking a lot about the challenges of rural health today, but Paul wants to know, what are some of the rewarding parts about running a small town hospital? Let's end on a positive note.
Great. Well, I'm going to tell you that I think our CEOs will say that on our program today, we'll go around the horn here and ask them that. You don't go in to be a small rural hospital administrator thinking you're going to make a whole lot of money. So there's got to be other rewards. I think a lot of it has to come to professional sources. So George, talk to us a little bit. Why are you there?
Because we get to take care of our family, our friends, the people who we know, and those individuals are in our hospital beds or in our outpatient clinic departments and so forth, and we know who they are, and we want to take care of them, and we want that long-lasting relationship that's either with the grandparents or with mom and dad or even with the kids. And so that's why we come every day, is so that we can take care of what would be maybe our external families. Yeah,
your larger family. Larry?
Yeah, I've always said it's personal, whether good or bad, it's personal. Sometimes things don't go the way we would like it to, whether it's from a care outcome or from the delivery of service. and you know you're going to see those people at the grocery store or at a ball game or somewhere out in the community. But you also dramatically, the positive outweighs the negative, because when we have those great stories, like George said, they're our friends, they're our neighbors, they're people we're going to see, and so it really matters. And whether it's the CEO or anybody in our facility, healthcare is still a wonderful occupation to be in, whether you're clinical or non-clinical.
Gary.
Well, and besides being able to take care of your mom, your neighbor, your bus driver, the experience that you can have in a rural hospital or location is second to none. In a larger institution, you get very specialized. And here, our surgery nurses do orthopedics, they do general, they do urology. Our ER nurses take care of our long-term acute patients. So you just have a breadth of knowledge and experience that's really far surpasses any other location.
Chad, it's got to warm your heart a little bit to hear this story about rural hospitals and the reward people have.
Yeah, it's tremendous, and I think it's inspiring from our SAS perspective as we go out and we visit with the hospitals from across the state. You know, a lot of genuine individuals that really care about their community and care about serving their family members, their friends, and their colleagues.
Yeah, it does me, and I think it's a good message for everyone out there who may be listening to think, think about that career. This is a great way to go, and the reward that these good folks have outlined and talked a little bit about how that has affected their lives, both deeply personally and from that community perspective, is just terrific. So this has been a great conversation. I want to thank all of our guests. Let's get some final thoughts. Chad, you're up first.
Well, again, thank you, Dr. Stites, for this opportunity to be here today. We're really excited about celebrating National Rural Health Day tomorrow. It's a great opportunity, as I mentioned, to be able to kind of recognize the hard work that happens in our communities day in and day out by our healthcare workers. So thank you again for that opportunity to allow us to share some of the great stories that are happening across the state.
Larry Vanderweg.
Yeah, Dr. Stites, thank you and all your staff for enabling us to do this. And it's a wonderful opportunity to provide care, whether you're in a large metropolitan institution or whether you're in the smallest of communities. It's a noble profession. We're all trying to do the best that we can to care for the people that we serve. And we've done a wonderful job coming through a pandemic, and we'll just continue on doing the best we can.
Thank you. George Stover.
Thank you, Dr. Stites, again for the opportunity to speak on behalf of our hospital in Lyons, and then also on behalf of all the hospitals, small, rural, across Kansas. It's imperative that rural health continue to be maintained. Even though populations may be decreasing in rural areas, there are people who are still there, and they need health care. And it's always important that we be able to maintain those facilities so that those individuals don't have to travel long distances just from the general medical needs. So it's imperative that we maintain our rural facilities, and so awareness is extremely important.
Thank you. Carrie Saya.
Thank you again, Dr. Stites. The podcast that you've put on and the KU Collaborative has been instrumental during the pandemic, so I really appreciate this continuing on past I can't say past the pandemic, but hopefully past the pandemic. It's been very instrumental, and those partnerships are so valuable. The collaboration that I have with Larry and George are just an example of how we can be stronger together, and we're stronger with the KU Collaborative, we're stronger with the information that's shared, and it is vital. We've seen what putting off care has done in the last 2 years, unfortunately, with our community, and we know that that will continue if our organizations aren't thriving into the future. So each of us are here to make sure that rural healthcare does continue to exist, and we just appreciate you taking the time this morning to allow us to have that voice.
Well, we're delighted to have you all here, and Bob Mosier, again, you've been tied to the collaborative and KDHE and the School of Medicine and a great family medicine doctor. Rural Health has been your life.
Yeah, it has, and I certainly do want to thank all of your guests for letting me participate in this today and the great work that they do. But I do really want to celebrate National Rural Health Day and recognize all of those folks across rural Kansas in particular that whether it's health or human services or social services that they're involved in that make our rural communities a little stronger and keep our citizens healthy. Thanks for what you do each and every day. And I know that while we'll celebrate the day, their work will continue each and every day, and they'll stay at the grindstone doing the work because, as they've mentioned, it's neighbors caring for neighbors, and they take it very serious, their role. So happy to be part of that, and happy to be celebrating with the Kansas Rural Health Association today on the Salina campus. Their annual meeting is going on today, and many of those folks will be going over to Hayes for the KHA Rural Health Symposium tomorrow. So a lot of activities going on today, a lot of chance for celebration of the great work that's taking place.
Thank you, guys. Doc Hawk, final thoughts today.
Yeah, I mean, I think it's just echoing all these messages with collaboration, and it has been so good, and we are continuing to work towards that, towards further collaboration and unification rather than division. We know there are so many issues going on out there, but we should work towards unification and collaboration. I had a patient yesterday who just talked to me about was waiting for an appliance, and it took like 6 months because of supply chain issues, and was just concerned because they never thought they'd see America like this, and I just was reminded it's not America, it's the whole world, and we are so grossly and finely connected to other countries around the world, to really everybody, that we really need to continue to work toward that unification and not that division, and this is a great example of that. So
yeah, it is. I think back to that live long and prosper from Star Trek. I always have to get that in. But it is true, and the more healthcare closer to home that people experience, the better they're going to do, because we know the further you are away from healthcare, the less you seek healthcare, and the more dangerous things are by the time you get that care. So this has been a really important program. We love the messages here. And I think the best message I've heard today is that healthcare and working in rural communities, it's not just a job, it is a community. It's more than profession, it's almost a calling. And I think when people experience that, they get connected in ways they may not have thought possible. Jess, back to you.
Dr. Stites, thanks so much, and thanks to our guests and to all of you for joining us today. We'll be back tomorrow morning at 8 o'clock with another episode of our Morning Medical Update. Until then, have a great day. Coming up tomorrow on the Morning Medical Update, what would you do to save your own child's life? Ask this little guy's mom, who worked hard for 3 years to improve her own health so she could donate her kidney. I'm Jessica Lovell. Meet mom, son, and the team of doctors who made it all happen. Thursday at 8 on the Morning Medical Update. I'm Alexis Del Cid on the next All Things Heart.
This body is half bionic and it's still going.
Her battle with cancer began at age 11. The trouble with her heart from the treatment decades later. Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.